Welcome everyone to Alan Hu Foundation Mental Health Lecture Series. I'm Chi-Ching Hu, co-founder of Alan Hu Foundation and host for your webinar. Today, Dr. Xavier Amador will present I'm Not Sick, I Don't Need Help, How to Help Someone Accept Treatment. We'd like to thank City of Pleasanton Community Youth Grant to fund this webinar. We'd also like to thank the Mental Health Association for Chinese Communities for providing simultaneous Chinese interpretation. And thank you to Ida Xiao for Chinese interpretation. Alan Hu Foundation's mission is to promote mental health, raise awareness, and remove stigma surrounding psychiatric disorders, and support fundamental research for cures. Please consider making a gift to Alan Hu Foundation by using the donation link in the chat box. And thank you for supporting our programs. Today, it is our great honor and privilege to introduce Dr. Xavier Amador. Dr. Amador is founder and the president of LEAP Institute. He is a world-renowned clinical psychologist, forensic expert, and author of 9 books, including the bestseller, I'm Not Sick, I Don't Need Help. His extensive work, books, and clinical research in schizophrenia, bipolar disorder, and other mental illnesses have been translated into 30 languages. Additionally, he has authored over 130 peer-reviewed scientific papers and has contributed his expertise to over 80 death penalty cases. Dr. Amador is also a family caregiver of 2 close relatives with schizophrenia and another with bipolar disorder. In this talk, Dr. Amador will speak about research on the prevalence, etiology, and the clinical significance of poor insight of persons with serious mental illness. He will discuss evidence that poor insight is a symptom of these disorders, not denial. He will introduce the LEAP strategy, Listen, Empathize, Agree, Partner, that helps people create relationships that lead to treatment, even when the person is suffering from anosognosia and does not believe they are ill. LEAP is an evidence-based communication program that turns adversaries into partners. It can be used to help adolescents and young adults to accept treatment and to change maladaptive coping mechanisms. The webinar is being recorded. The recordings will be available on the Alan Hu Foundation website and Alan Hu Foundation YouTube channel in about 1 to 2 weeks. Please subscribe to Alan Hu Foundation YouTube channel. And following the presentation will be a Q&A session. Please use the Zoom Q&A function to submit your questions. The presentation is for educational purposes only. It is not intended for medical diagnosis. If you have any persistent symptoms, please seek professional help. With that, I'm turning to Dr. Amador.
Thank you,
Welcome,
Chi-Ching.
Dr. Amador.
Thank you so much. I really appreciate the kind introduction. And I'm very impressed that you could pronounce anosognosia, which is a symptom I will be talking about. The title of my talk really came from a very specific relationship. The I don't need help, I'm not sick. I'm going to describe that in just a few moments. Before I do, I just want to tell you a little bit about LEAP Institute. We train people about the symptom of anosognosia, and the LEAP program is typically a 2.5 to 5 hour training program. So we do offer training that's very extensive. And we teach families, community members, mental health care professionals, even judges and police officers. In the upper right-hand corner is a QR code. If you go to the LEAP Institute website, there are free videos. So if you're intrigued by what I present to you this evening and want to learn more about LEAP, you don't have to pay anything. Go to LEAP Institute. Under resources, there are free videos. There's over a dozen videos there that can help you learn how to use LEAP. But let me start where I started in all this, and it was in the context of a relationship with my brother, Henry. This is a picture of Henry and me. Henry's looking in the window. I'm the little boy pretending to drive the car. And this picture was taken when we had immigrated as refugees from Cuba. Our father had been killed in the Cuban Revolution. Our mother landed in the United States with 4 children. I was the youngest, and no husband to help her raise us. And we were very, very poor and very frightened. We were refugees. My older brother, Henry, whose picture you see here, was much more than an older brother. He was like a father. He was more important, I think, my best friend. Why is that important? Because I want to talk about how mental illness and my reaction to his mental illness almost destroyed our relationship. Now, I want you to imagine 20 years after this picture was taken, I was in New York. I was studying to become a psychologist. I wasn't yet. I was just in college. Excuse me. And I got a phone call, and it was my brother. He was in Arizona living with my mother, our mother, and our stepfather. My mother remarried, wonderful man that we all referred to as our father. Our dad is the word, right? He called me on the phone and he said, "Come home quick. I killed dad," and hung up the phone. Now, I didn't think he'd actually hurt our stepfather, but obviously I was concerned. I called him back, and what I learned very quickly is that my brother Henry, who I was very close to, was delusional. He had a delusion that by playing the guitar, uh, waves were sent into our stepfather's head, causing him to trip and fall. He thought playing guitar had killed our stepfather. He had hallucinations. He was hearing the voice of the devil. So I knew something was wrong. I flew from New York, where I was studying as a college student, back to Arizona. And Henry was suicidal. He was very, very guilt ridden. He was sure that he had killed our father. And all of our other brothers and sisters uh, looked to me to help him. The reason it wasn't because I was a psychologist, because I wasn't even a psychologist. I was just 21 years old studying. I think the reason they asked me to go help Henry was because of the relationship we have, the relationship that's symbolized by this picture. We enjoyed each other's company. We listened to each other. We trusted each other. So I went and I spoke with my brother. I said, "Please get help. You need help. You're not well. Uh, you're hearing voices. You've got this, pardon the expression, this crazy idea that you killed our stepfather. You didn't." It took me a week to get him into the hospital. That's the first time anybody ever said to me, "I'm not sick. I don't need help." He even said to me, "You're the crazy one, not me." Now, I never used that word crazy, but he got very angry and defensive. The way I got him into the hospital is the way that many of us who are here together tonight have had to do it. I called the police. And I called the police not because he had committed a crime. I called the police because he was talking about ending his life, about suicide. So he goes to the hospital and he's treated with medicine to stop the hallucinations and the delusions, antipsychotic medication. And after a month, I was amazed how well these medications worked for him. After a month, we're sitting with his psychiatrist and his nurse, and the psychiatrist tells Henry, "You have schizophrenia. Medication you're taking, you'll have to take for the rest of your life if you want to stay out of the hospital." Henry nodded his head. "I understand. I agree." We came home. Our mother makes us dinner. I'm doing the dishes after dinner. And what do you suppose I find in the garbage can? Medication, the medication that had helped him so much in the hospital. So I got the medicine out of the garbage can. I went to his room. I knocked on the door and I said, "What's going on? Why aren't you taking this?" And he said again, "I'm not sick. I don't need help." And I said, "But Henry, 4 hours ago in the hospital, you said you understood." And he said, "No, no, no. That was 4 hours ago. I'm fine now." That started 7 years where our relationship looked like this picture. Henry running away from me, running away from police, running away from doctors and others who were trying to help him. During this 7-year period, represented by this picture of the man running away, during this 7-year period, he was homeless for a time. He was involuntarily committed to the hospital 3 to 4 times a year. Now, I was getting trained during this 7 years to get my doctorate in psychology, and I had a patient just like my brother. I was working on a psychiatric inpatient unit, and this woman said all the same things my brother said. "I'm not sick. I don't need your help. Leave me alone." She said worse things. She cursed at me. And I left the meeting very demoralized. And I went and I spoke with my supervisor because this was the last year of my training before getting my doctorate. And my supervisor, I'm telling him the same story I'm telling you about this woman. And he says, "Stop talking at her. She's not hearing you. Stop, apologize, and ask her questions. What does she, the most important question, what what do you want?" It's kind of simple, isn't it? So I went back out and I talked to her and I apologized. I said, "I wasn't listening to you. What do you want?" And the first thing she said was, "I want to get out of the hospital." I said, "I can help you with that. What else?" And she said, "I want my mother to stop calling the police because the police had brought her to the hospital." So I partnered with her on these two goals: getting out of the hospital, getting her mother to stop calling the police. She accepted medication. She got out of the hospital. Her mother and her and I met for a year in a clinic. After this experience and many others after it, just like it, I had this epiphany, this realization. I'd been doing everything wrong with my brother. Every time I tried to educate him that he had an illness, tried to convince him, tried to show him evidence that he needed treatment, he ran away from me. He ran away from the advice. He ran away from the explanations. So I called him and I said a couple of things. This is very important. I apologized. I said, "Henry, I am sorry for all the times I told you you had schizophrenia. I promise I'll never do it again." I kept that promise. Never told him again he had schizophrenia. Then I said a second thing. "Henry, I'm sorry for all the times I told you you needed to take medication. I will never do that again." And I kept that promise. Within 6 months of the change in me, not the change in him, listening, working with his goals, stop, I stopped trying to educate him that he had an illness. Within 6 months, he accepted an injection of antipsychotic medication that he stayed on for the next 20 years, the rest of his life. Sadly, he died in a car accident. It wasn't his fault. He was actually helping somebody else when he got hit by a car. But my point is that he was no longer going to the hospital. He had 2 volunteer jobs. He had a girlfriend. He was in recovery, and our relationship recovered. This is a picture of Henry and me some time ago now, maybe 18 years ago. I'm the one on the left, and he's on the right. If you look at how we're holding each other and smiling at each other, I think the picture tells you all you need to know. We were friends again. We trusted each other. He was in treatment. I asked him, it turned out to be the last year of his life. I asked him, "Henry, when I talk about you," and he knew I talked about him. "When I talk about you, sometimes people ask me, well, how about today? Henry's been in treatment for 20 years. He's not hallucinating. He's not delusional anymore. He's doing well. Does he finally understand he has schizophrenia?" So I asked him that question. And he laughed and he said, "No, no, 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 I don't have schizophrenia. You know that." And I said, "I did know that that's what he believes." And then I asked him a very important question. I said, "Well, then why are you taking these injections, this medication?" And he said something very important that is the focus of what I'm going to be talking about. One of the things I'm going to focus on. He said, "The reason I take these injections is for you, for me." And he mentioned 2 other people. So what's the headline here? Even when successfully treated, he still didn't believe he had mental illness for almost 20 years. And the other headline is he was still in treatment, even though he didn't think he had an illness. And the reason was relationships. And I'm going to be talking about those kinds of relationships. But I want to tell you one more story before I get into some research. We see stories of people with mental illness in the media, in the newspapers and in TV. But they're usually stories of crimes rather than stories of recovery. And here's one of those stories. This is a picture of a woman named Margaret Mary Ray. And Margaret Mary Ray was known in the US as David Letterman's stalker. What is it that was happening? She had a schizophrenia-related illness called schizoaffective disorder, and she had a delusion that she was married to the celebrity David Letterman. So she would go to his house. He'd come home from the TV studio where he was taping his show, and this woman would be there, this stranger. But to her, she was not a stranger. From her, mind, he was her husband. So he would call the police, have her arrested, and this went on for years. She ultimately died from her illness, and what I'm referring to is suicide. Um, the suicide rate in people with the illnesses I'm going to be focusing on tonight, which is schizophrenia, schizoaffective disorder, bipolar disorder, those serious mental illnesses, the suicide rate is 10%. 1 out of 10 people die from suicide. The biggest predictor is not being in treatment. So I want you to remember this story because I'm gonna come back to this. So denial of illness impairs common sense judgment, doesn't it, about the need for treatment and for services? Would you agree with that? Most of you, I'm sure, would agree with that statement. I actually don't agree. If I take the perspective of my brother or the millions of people, tens of millions all over the world with serious mental illness, if I take their perspective, or the woman I just told you about, Margaret Mary Ray, from their perspective, it is common sense to refuse treatment. It's intelligent from their perspective. Let me say this a different way. A question for everybody here tonight. How many of you would inject yourselves with insulin, take a shot of insulin, knowing you don't have diabetes? Anybody? I'm sure not. And the reason you wouldn't is because you don't need it, you don't have diabetes, you're not sick, you don't need that kind of help. The insulin could actually hurt you. So denial of illness and refusal of treatment, actually from the perspective of the person who doesn't understand they're ill, is actually common sense. It's actually good judgment from their perspective, not from ours. I understand that. But are we dealing with denial? In most cases, we're dealing with a symptom called anosognosia. And this was first described by a neurologist over 100 years ago. And he described people who were paralyzed on one side of their body and they didn't know it. That you couldn't even, and I've evaluated someone like this, many patients like this, neurology patients with brain damage, paralysis, and they don't know it, they don't believe it. They have to be restrained in bed because they'll try to get up out of bed and they'll fall down because of the paralysis. Now, if you want to learn how to pronounce this, it's very useful if you want to talk, if you're a family member and you want to talk to your loved one's doctor about it. This is how you can pronounce it. An, nose, egg, nosia. So I always think of a woman named Anne who knows an egg, and she's very nosy. Anosognosia. I would invite you out loud right now, watching me, on the count of 3, to pronounce this word so beautifully as Chi-Ching did. 1, 2, 3. Anosognosia. Again, it's important to know how to pronounce this if you come away from tonight thinking this is something that's important to talk about. Now, we've known for 50 years that in patients with these serious mental illnesses, the frontal lobes of the brain are not functioning properly. And the question that the study I'm going to show you right now posed, the question we had was, do we see anosognosia in neurological patients, patients with severe trauma to the brain, when the frontal lobes are damaged? This is a neuropsychological test that is very common. You ask the patient to draw this clock. Now, in our study, we asked the patient, who I'm going to show you his clock in a moment, I asked him, how do you think you'll do? And he said, no problem, I'll be able to do it. Most of us would, right? It's an easy drawing. This is what he drew. Did he have a problem? We all would agree he had a problem. I asked him, how did you do? What do you think of your drawing? And he said, it's a very good copy. So even when presented with evidence that he had a problem, a neurological symptom, he didn't understand it. When I started pointing to the number 12 inside the clock and then the 12s outside the circle, he, instead of realizing, oh, this is a terrible copy, he got angry and paranoid and he pushed the paper away and he said, that's not my drawing. So not only did he not see that he had a symptom, he confabulated. What are confabulations? Basically, our brain is making up stories to fill in gaps in our perception and in what we believe to be true about ourselves. So that was a confabulation. And I remember with many patients I've worked with over the years who have anosognosia, an unawareness of their schizophrenia, for example. When I've asked them, why are you in the hospital? They would confabulate and come up with all kinds of stories, explanations that had nothing to do with a belief that they had an illness. So let me talk about some research on anosognosia in psychiatric patients. What I just showed you was a neurological patient. We published a study back in 1991, a review paper, and I was very interested in the what experiments, what empirical database was there on this problem of awareness of illness in people with schizophrenia and related disorders like bipolar disorder. So what did we learn? We learned that not that much research had been done, and then we had a hypothesis, however, that frontal lobe deficits will predict poor insight. Because again, we'd known for decades when this paper was published that schizophrenia, bipolar patients, related disorders had frontal lobe problems. So maybe those patients with frontal lobe deficits would be the same patients who say, I'm not sick, there's nothing wrong with me. The same patients that have poor insight. Well, the field was very interested. This was done out of Columbia University in New York City. But people all over the world tested this hypothesis, this idea. And this is just a partial list. There are 3 times this number of studies, all finding that neuropsychological deficits in the frontal lobes, executive dysfunction is what we call it, predicted who would say they had no illness, who had poor insight. So the research, starting in 1993, is already pointing to the problem being another symptom of the brain disorder, not denial. Now, this is how the brain is functioning, how it's working. What about the way the brain looks? These are studies that involve brain imaging and also post-mortem studies, so dissecting brains after the person has passed away. These are 20 studies that compared the brains of people with schizophrenia who understood they had schizophrenia and compared their brains to schizophrenia patients who did not believe they had mental illness. All of them found significant differences between those two groups, and most of the brain regions that were abnormal were in the prefrontal and frontal cortex of the brain. So earlier slide, the brain is dysfunctional in the frontal lobes. This slide is research showing that there are neuroanatomical differences and even damage to the frontal lobes of the brain in patients who do not understand they have an illness. All of these studies, but three of these studies had subjects who had never been treated with medication. What does that tell you? 2 things. Medications didn't cause these brain differences. And the other thing it tells us is that even first episode patients, even patients who had never been treated from the very beginning of their illness, are showing these brain differences. And here's an example. One of the brain differences is reduced gray matter, which are the brain cells, the neurons rather, in the prefrontal cortex. So one more study. This is part of what's called the DSM field trials. The DSM is the diagnostic manual we use in the United States to make psychiatric diagnoses. And this was part of a study that was involved in revising this diagnostic manual. We found that 60% of the patients, and here I'm showing you schizophrenia patient results, did not understand they had illness, moderate to severe unawareness of illness. We found the same results. I'm not going to show you those slides because that's what we do in the longer training. But the same results were in schizoaffective disorder patients and bipolar patients. Now, we also did something nobody had done before. We looked at awareness of symptoms, and we found all kinds of deficits in the patient's ability to understand they had, disorganized speech, thought disorder, or hallucinations. So there are two things here I want to emphasize. This study found that about half of all people with these illnesses did not believe they had an illness. And this has been replicated in many studies, over 300 studies now since 1991, when this was done, show that it's about half of all people. And importantly, there's also unawareness of symptoms or signs of illness. So we have different deficits, different problems in self-awareness. It's not simply stigma or denial, far from it. So let's talk about the DSM, that diagnostic manual that I mentioned. I was the lead co-chair with another doctor, Michael Flaum, and we were asked by the American Psychiatric Association to revise all the text in the DSM for the schizophrenia and other psychotic disorders section. We got a group of experts from all over the world to read the research literature. And this is what our group of experts arrived at a consensus about. A majority of people with schizophrenia have poor insight regarding the fact they have an illness. Evidence suggests that poor insight is a manifestation of the illness rather than a coping strategy. Now, that's kind of cumbersome language. What are we saying? It's a symptom or a sign of the illness. It's not denial. What else is in the DSM? It may be comparable to what we see in neurological deficits termed anosognosia. Now you all know how to pronounce it, right? And this symptom, it's a symptom, it's not denial, predisposes the person to not accepting treatment, to non-compliance with treatment. And it predicts all kinds of other negative outcomes like higher relapse rates where the person has to be hospitalized, more involuntary hospitalizations, forced treatment, poor functioning in work, in relationships, and a poor course of illness. And this is on page 304. If you want to talk to your loved one's doctor, you can ask them to pull out their gray DSM, the DSM-4, and turn to page 304. But this was 24 years ago. What do we have now? Well, we have the DSM-5. And I assisted with this one. I was not the lead. I was not one of the chair people, but I did assist. Here's what's in our current diagnostic manual that all psychiatrists, psychologists, nurses, social workers use. Unawareness of illness is typically a symptom, not a coping strategy. It is comparable to what we see in neurological deficits following all kinds of brain damage, termed anosognosia. So this is in our DSM. It includes unawareness of symptoms. Remember the slide I showed you from the DSM field trials? So it's not just unawareness of a diagnostic label, it's also unawareness of signs and symptoms of the illness. It's common in schizoaffective disorder, and this symptom of anosognosia is the most common predictor of non-adherence to treatment. What does non-adherence mean? Refusal of treatment, or when they start treatment, the person drops out. Like my brother Henry, he threw the medicine in the garbage can. And why is that? Because of the anosognosia. It's common sense. If I'm sure I don't have mental illness, why in the world would I take pills or injections? So let's talk about pills for a moment. There's a big problem with oral antipsychotic medication, pills and capsules. And the problem is that people either refuse them or stop taking them without telling anyone, like my brother throwing away the medicine. This study found between 50 and 75% of patients with schizophrenia don't take their medication at all or only take a little bit. So they're still ill. They're not therapeutically treated. This finding has been replicated dozens of times. This is not just one study. There are dozens of studies that find this rate, 50 to 75% on oral medication stop. This study looked at people over time. Within 10 days of starting an antipsychotic medication in schizophrenia patients, 25% had stopped. Within 1 year, half were off the medication. Within 2 years, 75% had stopped taking the medication. This is a big problem, not being in treatment or dropping out of treatment. And remember what I showed you earlier. What's the biggest predictor of this problem? Anosognosia, not understanding you have an illness. So when we're successful, and the whole LEAP program that Chi-Ching talked about, which I'm going to introduce you to, we don't have time tonight for me to train you in that program, but you're going to get a sense of it. Once we're successful using LEAP or approaches like it, what should we offer? What kind of treatment? Well, long-acting treatments given by injection are superior. Most people find 50% on the pills and capsules, oral medications, stop. This study and others found that over 83% stayed on the medication. Okay, only 17% dropped out. Now, why is that? Think about it. If you have anosognosia, you know you're not ill. Every day you've got to put, maybe sometimes twice or 3 times a day, this is a mint, you got to put a pill in your mouth and swallow it once, twice, 3 times a day, every day. Eventually, your frustration, your anger at your family, at the doctors is going to win, and you're going to throw it away because you know you're not sick. From your perspective, there is no illness. Whereas with long-acting treatments given by injection, you go to an appointment once a month. Some of the medications once every 3 months. Another one of the medications just twice a year. So the person goes to an appointment and meets with a nurse and gets a shot once a month, or only once every 3 months, or only twice a year. And it sort of makes sense intuitively. It's a smoke detector. You know when people do not take their medicine because they missed their appointment. It also reduces tension. I don't have to ask my patients, are you taking your medication when they're on an injection? Because I know if they kept the appointment or not. And if you're a family member, you don't have to ask your family member, are you taking the medicine, the pills, because they made it to their appointment. Also, if somebody misses an appointment, you can use LEAP and other approaches like it. You can use your relationship to build trust to help that person make a new appointment. So to summarize, what do we know about awareness of illness and treatment acceptance? We know that the top predictor of long-term engagement in treatment, medication adherence, is having awareness of the illness. What do you think is a close second predictor? Turns out it's relationships, just like what my brother said, but it's a very particular kind of relationship. I'm summarizing a whole body of research. It's a relationship where the person feels listened to without judgment. So when the person says to a loved one or to a doctor, I'm not sick, nothing wrong with me, the CIA really is after me, the doctor or the family member doesn't try to convince the person they're wrong. They listen and they're empathic, and they interact with a lot of respect. So a lack of judgment and tremendous respect. So if a patient like my brother came to me and said, my problem is my family, they keep calling the police, the devil is talking to me. My brother used to hear voices of the devil. I would listen in a respectful, non-judgmental way. What does that mean? I have to be active in my listening. So what I would do is reflect back to the person what they said. For example, so what you're telling me is You're not mentally ill, and your family should stop calling the police on you because your problem is the devil is talking to you. Did I understand that correctly? That would be how you use respectful, non-judgmental listening. And the person feels those things, respected and not judged, and they know that I have an opinion that I'd like them to try treatment. So there's three elements: respect, a lack of judgment, and I have an opinion that I give in a very humble way that I think you ought to try treatment. I could be wrong. Maybe it won't help you, but I don't want to argue with you, but I'd like you to try it. That's one of our tools in the LEAP program, what I just did. You apologize for your opinion. You acknowledge you could be wrong. You ask the person not to argue. Those three things. So what do we know about anosognosia for serious mental illness and acceptance of treatment? We do not win on the strength of our argument. You cannot convince the person they have an illness. What happens is we win on the strength of our relationship. We don't convince the person they have an illness. We convince them that we care about them, we respect them, and they listen to our opinion. And our opinion is, why don't you try treatment? Just like with my brother, same thing. So when talking about anosognosia, how you talk about it really matters because it changes how you think about it. So do not say the person does not accept she has an illness, because that suggests it's a choice, right? Anosognosia is not a choice. Refuses to acknowledge he has a mental illness. Let me ask you a question. Would you ever say that somebody refuses to stop hallucinating? No. And why wouldn't you? Because you know it's not under their control. Don't say the person is in denial because it's not denial. This is a symptom of the brain disorder. It's not denial. Doesn't admit as if the person can admit it. Won't admit or refuses to admit. This kind of language is inaccurate, it's incorrect, and it leads to stigma about the person, that they're being difficult, they're being stubborn. So how can you talk about it? You can say things like, he cannot comprehend he has an illness. She is unaware, just simply unaware, unable to see or understand that they have mental illness, right? It's cognitive blindness. Has anosognosia for mental illness is ideally what you would say. Now, what does it feel like to have the symptom? There's a role play I often do when we do our trainings where I'll ask somebody who's married to volunteer. And then I tell the person, you know what, you think you're married, but you're not. And I can prove it to you. And I, in the role play, provide them with all kinds of evidence that they're not married to the person they think they're married to. And I ask them to imagine being brought to a hospital and treated for what we are all saying is a delusion, that they're not married. And then I ask the person, this goes on for a whole year. Every time you try to see your wife, the police are called. You're brought to the hospital. Every time you try to call your wife, the police are called and you're brought to the hospital. Do you think after a year of those experiences, never being able to speak with your spouse, and when you try, the police take you to a hospital, do you think then you'd finally understand you have a mental illness? And my volunteers in this role play all say, no, of course not. I know who I'm married to. That's what anosognosia for mental illness is like. The belief that the person has no illness is as rock solid as their belief that they're married to who they're married to. You can't change it. So when helping someone with anosognosia, education and interventions do not work. We can't expect the person to be grateful when we tell them they're ill and they know they're not, or receptive, or expect them to accept, help or treatment. What we can expect is for them to get frustrated with us, get angry, have fear and anxiety around us because we're trying to force them into treatment, loneliness. The people that I've worked with anosognosia, thousands now over the last 40 years, are some of the loneliest people I've ever met because they have everybody around them telling them that they have mental illness and they know they don't. And we can also expect the person to refuse help and treatment. So in the few minutes I have left, let me give you an overview of the LEAP approach. There are 7 tools. There's that active listening I was previewing earlier. Without judgment, with respect, we're actively listening to the person. We empathize with them. We say things like, I can see why you're so frustrated that people think you're ill. You know, I'd be frustrated too. So we normalize their feelings. We find areas where we can agree. We're not going to agree that the person has an illness because the person doesn't know they have an illness. But we can agree on other things, getting a job, having a relationship, staying out of the hospital. Many things we can agree and partner on. Now, there are 3 other tools. We delay giving opinions that the person would find harmful. So somebody who believes there's a CIA conspiracy, a patient I was working with recently, asked me, well, Dr. Amador, do you agree? Because I was listening actively with respect. And he made the mistake of thinking I agreed with him. It sounds like, he said to me, it sounds like you understand my problem with the CIA. Well, I want to delay giving that opinion if I can. So what I said to him was, I promise I'll answer your question about the CIA. Before I do, can you tell me more about that argument you told me about that you had with your mother? Would that be okay? I asked permission. And eventually he let me delay, and I had more opportunities for active listening and being empathic with him. And eventually he said, oh, I really want to know what you think. And then we give our opinions with the 3 A's. We apologize. We acknowledge that we could be wrong, our fallibility. And we ask the person to agree to disagree. So what did I say to this young man? I said, you've asked me about the CIA, and I'm really sorry I have this thought. I could be wrong. I don't see the same evidence you see that the CIA is following you. I hope we don't have to argue about it. So do you see how humble and respectful my opinion is? What I used to say when I used to argue with my brother, the picture on the face of the book is the picture I showed you before, is Henry, you know you're ill, which he didn't. You know you're ill. You know you need to get treatment. That's a very different way of giving an opinion. We also apologize, the last tool, for acts and interactions that were hurtful to the person. So what's the overview of these tools? We listen by reflecting back without judgment, reactions or contradictions. We express empathy for feelings that come from the beliefs that nobody wants to talk about, the delusions, the anosognosia, what the person wants. We find areas of agreement. Abandon your goal of trying to convince the person they have an illness. It won't work. We partner on goals that we can actually agree on, like staying out of the hospital, finding work, finding love, a relationship. We delay giving hurtful and contrary opinions. We redirect the person, ask permission. Can I tell you later? And when we give our opinion, we give it with humility and in a way that's respectful. And then we apologize for acts and interactions that felt disrespectful, frustrating, or disappointing to the person. Learning LEAP is just like learning a new language. Go to our website, look at the videos. If you want to read my book, you can read my book. There's free chapters on the NAMI.org website. But practice with other loved ones, or if you're a mental health professional, also like me, find a colleague and say, I'm going to have this difficult conversation with my loved one. Can you pretend to be him? And here's what he's going to say to me. And you can practice that listening, the empathizing, the delaying giving opinions, giving your opinion in the way that I've taught you. I previewed for you. I didn't teach you completely yet. And here I'm going to end with general guidelines. So you absorb what you've heard. Don't react to it. Don't disagree. Absorb it. And this involves reflective, active listening. Then we emotionally connect with the person through empathy, and if needed, through apologies. I'm sorry for calling the crisis team and the police and you're having to go to the hospital. I know that was very hurtful to you. That would be an example of an apology. Only after you've absorbed and emotionally connected can you start to problem solve. And that's when we get to agreeing and partnering. You use each of these tools as you need them. So imagine a tool belt with all 7 of these tools in it. I may start with giving my opinion, or with delaying giving my opinion. I may start with empathy or start with reflective listening. These are tools that grew out of research that we've done um, to create this evidence-based, this science-based approach to gaining the person's trust, so they'll listen to our recommendation that they try treatment, not for an illness. Maybe it's to help them sleep. Maybe it's to help them with the anxiety they feel if they have paranoid delusions. Maybe it's to help them with depression. So we don't tell them you need this because you've got bipolar or schizophrenia, whatever. If we can help it, we talk about problems they see that they have. So thank you very much for your attention. I'm a couple minutes late, but let me just direct you to the resources again. On the QR code, you'll go to the Leap Institute website, resources, free videos. There's all kinds of videos that will teach you much, much more than I've been able to do in 45 minutes about the Leap approach.
Right. Thank you so much, Dr. Amador, for sharing your knowledge and sharing
welcome.
the LEAP strategy and approach with us. And thank you so much for sharing your brother Henry's story. And I believe Henry's story benefits a lot of people. So now we open up to Q&A.
Okay.
Let me read a few questions from the pre-registrant, and while waiting for more questions coming in.
Okay.
So the first question, my kid with a high-functioning ASD, depression, anxiety, and suicide ideation, and will turn 18 in 6 months. I worried they'll refuse treatment at 18. How do I use the LEAP to help them receive treatment?
Such a good question. And I don't share this often, but I'm going to share it with this group today. Ching. I also have a son with schizophrenia, and I was able to force him to be in treatment. And I was very scared when he was turning 18. And I talked to him, and he said, "Dad, I don't need this medication you've been forcing me to take. I'm going to stop." You know what I said to him? "Son, that's your choice, and I will respect it." And he said, "So it's okay with you?" I said, "Well, no, I didn't say that." And then I did the 3 A's. "I'm sorry I have this opinion, son. I could be wrong. I don't want to argue with you. I'd like you to stay on the medication." And you know what he did? He literally put his arm around me and said, "All right, I'll do it." So what do? Learn how to leap, reflectively listen, be empathic. Don't argue with your child. Just say, "I understand your perspective. You don't want to be in the treatment." You might even say something like, and we teach this, "If I was in your position, I wouldn't take it either." That sounds scary, right? But you're going to give your opinion. You ask, "Can I tell you what I think?" And when you ask somebody that, people always say, "Yes, of course." Then you say, "I'd like you to stay in treatment." So that's a quick answer to a complex question.
Yeah. Thank you so much.
Sure.
Okay, next question. What about those mental illness patients who scared about their serious side effects from the antipsychotic medication? I would think that how can we use a LEAP strategy or approach to help them who has a concern about serious side effect of antipsychotic medication?
What we do is we acknowledge and respect their concerns and make sure that the person feels heard. So you're worried about weight gain. I can see why you're worried. I'd be worried too. And then you ask the person, "Can you talk to your doctor? Maybe there's a different medication that we can try." There's over 20 antipsychotic medications. And if one of them is causing side effects, you can try something different. I have borderline hypertension. I took a medication for my blood pressure that made me dizzy. I didn't want to take it, and I complained. And I didn't just throw it out and say nothing. I talked to my doctor. I talked to my loved ones. and I tried something different and it worked really well. So let me summarize my answer. Respect the person's complaint about side effect. Tell them you understand it. And then suggest, don't tell them, suggest, why don't we talk to your doctor and see if there's something that won't give you this side effect?
Okay, great. Thanks. Next question. This is a Chinese question. It's a little hard to understand, but let me try to
Okay.
translate it. Um, does it pose a high requirement to learn about LEAP and apply this strategy to a patient from the patient's relatives?
No, we teach the people we teach the most are the relatives. So the way you can learn this is either to arrange for a training. Again, it's at least 2.5 hours, or look at the videos. They're not in Chinese, I'm sorry. But maybe Alan Hu Foundation will translate them for me. They're free. They're free on the website. We
Yeah.
don't make any money from it, and we'd love it if they were in Chinese. So
All right.
sorry, but I think it's a good idea. Come on.
Yes, I think so. Yes.
Yeah,
Yeah, we'll
you can
consider that.
subtitle it in Chinese.
Oh yeah, yeah, yeah.
Yeah.
I think definitely, trying to disseminate such knowledge is gonna help people. Yes.
Well, you have my permission. I'll work together with you if you decide you want to do that.
All right. Thank you so much.
Sure.
Next question. Does this mental illness patients also have a tendency to blame others for
Oh,
everything they don't want to take responsibility for or accept? I guess it
oh,
is probably is this also
yeah.
anosognosia?
Yes, but let me disagree with
Hmm.
something. Um, it's very common that people with anosognosia and psychosis, like delusions, will blame everybody around them. But this is because of the brain disorder. It's not because the person is, uh, uh, I don't know how to say it, arrogant, or a terrible person. It's because when you have these illnesses, the alarm system in the brain, it's the amygdala part of the brain, is telling the patient there's danger, there's danger. So the patient looks around because they feel they're in danger. And who do they see in front of them? Their family. And the family becomes the focus of the delusion. So the person ends up blaming the family for why they're not working, why they don't have love in their life, why they're going to the hospital. It's your fault, it's your fault. But that's a function of the brain disorder, convincing the person they're in danger, and they don't have insight. The brain disorder also is convincing the person they're well. So who's left? It must be the family who's doing this to me, or friends.
Hmm.
Does that
Okay.
I hope does that make sense, Jiching?
Yes, yes.
Okay.
Um, Next question is about the patient is aware of the illness, but doesn't feel confident about the treatment. Or
Uh,
yeah, so can LEAP help?
yes, absolutely. Because LEAP is not only about well, LEAP is first and foremost about repairing relationships and building trust. Once the person trusts me, I can then make suggestions, and they're more willing to listen to my suggestions. So I can say, I know, and I would reflectively listen. I know what you're telling me is the medication doesn't help you. I understand that. Do you feel I understand? We ask the person, do they feel understood? The person says, yes, I believe you understand, Dr. Amador. And I said, would you do me a favor? We asked for a favor with LEAP. Would you just try this one other medication and see if it does anything for you? So again, it's the LEAP approach absolutely is for someone like the person who asked the question just asked about. You build a relationship where the person cares about your opinion, and in this case, your opinion is try a different medication.
Hmm. Okay. Next question. The patient actually take medicine for many, many years, but suddenly stop, decide because no longer needed.
No longer need it, right?
Can LEAP help? Apply
Absolutely.
LEAP.
It can help. I've seen it work. We've done research with patients like this, and basically, this is so important. When I talk to such a person, I want to understand. I want to understand their reasons for stopping, and if they tell me, "I'm well now. I no longer need the medication," I absorb that. How do I absorb that? Through reflective listening. So I
Mhm.
would say to that person, what you're telling me is you needed the medication before, but you don't need it anymore. Is that right? Yes. Then I would ask them, can I share my opinion about this? And the person says yes. Then with LEAP, I would say, look, I'm sorry I think this. I could be wrong. I think medication probably would still help you. And I don't want to argue with you. Would you be willing to try it? To try to stay on for another 6 months? Just try it. So the short answer is yes, LEAP does help in those situations. But I'm trying to give you a little bit of a preview, a feel for what it would sound like.
Yes, thank you. Thank you, Dr. Amador. This is very helpful. I think a lot of examples that these are real life examples that you can share with us that how to approach this. That will be very, very helpful to people.
Good.
Um, and that the next question, if the person's very emotional, angry, shut down, not listen at all,
Mhm.
what should we do? This is.
Well, it's a good no, it's a really good question. We at the LEAP Institute, we train police officers who are
Mhm,
EMTs, emergency medical technicians, who are the first people on the scene when somebody's in crisis and emotional and angry. And they love our program because the very first tool to help someone calm down is reflective listening. Tell me what's going on. What are you so angry about? And you reflect it back, and people tend to calm down. We all want to feel heard. That's a human condition. I want to feel like you hear me and you understand me. And when someone's angry and upset and emotional, if you can help them to feel understood and heard, people calm down. Not every time, but most of the time. Yeah.
mhm. Okay. Uh, so let me switch. Next question. How do we use LEAP to help a person with developmental delays, disabilities, and autism spectrum disorder?
The exact same way in the examples I've given.
Mhm.
You really want to get, if the person's telling you what they're upset about, don't disagree, don't contradict, listen, actively listen. You know,
Mhm.
and we use LEAP with people with dementia as well. Same thing, who get agitated and angry because they think you've forgotten something, and it's their Alzheimer's, is they're the ones forgetting. Well, you don't try to convince them they have a problem. You reflect back. So what you're telling me is I'm the one forgetting everything. I can see why you're upset with me. You know, and then eventually you give your opinion. You know, but yes, you can use this with people with developmental disabilities.
Okay. Next question. How do we use LEAP to support veterans to be more willing to access therapeutic
Access.
intervention? Access.
Same answer, but I'm going to add something.
Mhm.
If a lot of VAs in the United States, Veteran Administration hospitals, have peer programs where you have other veterans who've gotten treatment and have gotten better because of treatment, you try to introduce them to a peer, to someone else who is like them, and let them share their story of success. Really important. Peer support is extremely effective.
Mhm. Okay, great. And thank you so much, Dr. Amador. I think it's about
You're
time.
welcome.
We still have
Okay.
a lot of questions, but I
If
think
people
Mm.
I'm sorry to interrupt, apologies, but if people go to the Leap Institute website and fill out the contact form, you can send me your questions, and it may take me a day or a week, maybe even 2 weeks. I answer every question that comes in. So you can
Oh,
still
thank you
ask
so much.
questions after this. Yeah,
Yeah, wonderful. Thank you so much, Dr.
you're
Amador.
welcome.
Yeah.
Okay.
Yeah. So we're going to close, and thank you everyone for joining our webinar, and we hope to see you again in the next webinar. Again, this webinar is being recorded. The recordings will be available on the Alan Hu Foundation website and the Alan Hu Foundation YouTube channel in about 1 to 2 weeks. Please subscribe to Alan Hu Foundation YouTube channel. And please also take a moment to fill out a short survey. Your input is critical to us to improve our program. I will leave the donation QR code for a few more minutes, and thank you for donating to support our programs. With that, I'm closing the webinar. Thank you so much, Dr.
You're
Amador.
very welcome. Thank you for what you do. I appreciate your foundation very much.
Thank you. And thanks, everyone, and take care and stay well.
Thank you.
Thank you. Bye-bye.